Thank you.
Assalamu alaikum. Thanks, Dr. Tania, for giving me the floor. My heartful gratitude to all the mentors of OGSB for creating such a wonderful platform. I'm going to tell a story about lockdown. 2020, the whole world seems to stop at that time. A PRAMI patient at her 32 weeks of presentation with pervaginal watery discharge in a city where NICU support was not available. She has hypothyroid and PCOS. Moreover, she is your relative. What should we do? Welcome to all. At first international, my paper is on and AFI measurement by serial ultrasonography to prolong the latency period and improve neonatal outcomes at low resource setting. Preterm prom complicates approximately 3% of pregnancies, lead to 1/3 of preterm birth. That implies high risks of neonatal mortality and morbidity, both because of prematurity and antenatal exposure to amniotic infection and inflammation. Established management of preterm prom include a standard antibiotic regimen, steroid, and routine maternal and fetal surveillance. An alternative approach of management includes individualizing antibiotic therapy based on urine culture and sensitivity, progesterone, oral and intravenous hydration, and fetal surveillance. Several studies found intravenous hydration increased amniotic fluid index of mothers in pregnancy and improved oligohydramnions. Prolonging latency has a considerable impact on reducing preterm birth. Provides an opportunity to administer risk-reducing interventions before birth, although there are conflicting results on whether latency is an independent contributor to adverse neonatal outcomes. The present study was done to infer the impact of individualized management strategies on preterm prom cases with different latency periods at low resource setting by maternal hydration, amniotic fluid index measurement, and CRP monitoring. This is a retrospective study done at Kushtia district from January 2019 to December 2021. Sampling technique was consecutive and convenient with 21 sample size. Inclusion criteria was diabetic mellitus, and pregnancy-induced hypertension. Gestational age at the time of preterm prom and gestational age at birth are the primary variables. Outcome variables are maternal outcome and fetal outcome. After prom assessment, if the sign of active labor present, then go for delivery. If no, then enrollment in the study. Maternal hydration, oral antibiotic, steroid after 28 weeks, ultrasonography of pregnancy profile done for fetal weight and AFI measurement. Placental vascular status assessment for uteroplacental perfusion level evaluation. Complete blood count, CRP, and urine for CS is done. According to culture report, if culture is positive, then depending on microorganism isolated, ad hoc antibiotic for 7 to 10 days. Otherwise, broad spectrum antibiotic for 7 to 10 days. Follow-up ultrasonography before discharge with AFI measurement. Discharge with advice of complete bed rest and don't hesitate to come for warning sign. Patients counseling about fetal movement count after 28 weeks, personal hygiene maintenance, avoid coitus, or sterile vulval pad. Report if least fetal movement, fever, color change in pad, abdominal pain with hardening of uterus. Initial follow-up after 7 days, fetal and maternal surveillance does, but most of the patient report within 15 days. Up to 34 weeks, routine maternal and fetal surveillance done. If AFI reduced, then maternal hydration is given. Decision of induction is triggered by appearance of danger sign and increased CRP. Initial bolus dose of IV fluid with normal saline and amino acid solution is given after hospitalization for maternal hydration. Encourage oral fluid intake. Management was different from patient to patient with the target of continuation of pregnancy as far as possible, fetal weight enhancement, fetal lung maturation, and infection control. Frequency distribution according to age of the patient, most of them between 20 to 25 years of age. 58% patients are primigravida. 15 patients enrolled in the study at their 28 to 30 weeks of gestational age, and 70 patients delivered after 34 weeks of gestation. 10% delivered by normal vaginal delivery. Latency improved more than 7 days in 90 cases. Latency to delivery 6 to 7 weeks, and gestational age at delivery average 34 weeks, and none of them need NICU admission. In this study suggested that a prolonged duration of pregnancy after preterm prom and a reduction in preterm birth, not a single baby need NICU support. This finding was in line with other studies. Monac et al. Found the similar findings. Similar results were found in a prospective nationwide population-based cohort in France. Individualized management of preterm premature rupture of membrane may prolong pregnancy duration and reduce preterm birth after 32 weeks of gestation, thus reduce the need for neonatal support and neonatal intensive care unit admissions. These are the recommendations. Antibiotics should be administered to patients with preterm prom because they prolong the latent period and improve outcomes. Maternal hydration, AFI on ultrasonography, maternal CRP can be worked as a fetal surveillance tool to low resource setting to increase latency period in preterm prom monitoring. These are the limitations of the study. Bibliography. And this is the picture. First picture is the first case, with which I started the scenario. This baby is born after 35 weeks. Second picture is 32 weeks baby. His latent period from 26 to 32. And third picture is Shumita with her baby. And this is the highest latent period survived from 22 to 35 weeks of gestation. Thanks.
Thank you, Dr. Shamri Sultana Trina, for your excellent presentation. Now I am requesting our third speaker, Dr. Dina Laila Hussain, Junior Consultant, Dhaka Medical College and Hospital, to deliver her presentation. Dr. Dina Laila Hussain.
Thank you, Dr. Tania, my honorable advisor and respected chairperson, and my learned audience. Assalamu alaikum. I am Dr. Dina Laila Hussain, and very much delighted to present my study in front of you. My study is on preconceptional counseling, a gateway to evaluate a patient with recurrent pregnancy loss. As we all know that preconceptional counseling is an important piece of care for reproductive aged women where provider can identify or modify risk factors to improve maternal health as well as birth outcome. Preconceptional counseling plays a key role in preparing a woman for pregnancy. It emphasizes the importance of physical assessment, risk screening, vaccination, and counseling. Recurrent pregnancy loss is an emotionally traumatic event for couples and challenging issues for the high-risk pregnancy specialist. Regarding definition of RPL, long been debated and differ among the international societies. Here is the comparisons of definition of RPL among the 3 international guidelines, where the important trait is consecutive, where RCOG defined as consecutive 3 losses, ASRM defined as consecutive 2 losses, and ISHRE defined as consecutive or non-consecutive 2 losses. In first trimester, usually RPL due to genetic abnormalities or immunological causes, and very important is antiphospholipid antibody syndrome. And during second trimester, it is cervical weakness or due to congenital uterine malformation. But 50% still remain unexplained. It affects 1 to 2% of all couples trying to conceive. About 80% pregnancy loss is occurring in the first trimester of pregnancy. In most of the places over the world, it is, however, common practice to investigate couples following 2 pregnancy loss. Pre-pregnancy monitoring and support increases the chance of live birth. So my objectives of this study were during preconceptional counseling to find out the risk factors among the RPL couple that might be responsible for repeated pregnancy loss and to assess the health behavior of the RPL couples. My study was a cross-sectional study which was conducted OPD Fetal-Maternal Medicine Unit, Department of Obstetrics and Gynecology, Dhaka Medical College Hospital from October 2020 to September 2021, and my sample size was 69. I was selected those who were attending for preconceptional counseling with history of 2 or more consecutive pregnancy loss. All necessary information, including history, clinical findings, were obtained by pre-designed data collection sheet from the client during in-person interview. Results showing about 50% belongs to the primary RPL, whereas 43% were belong to secondary RPL. And most of the study also shows that primary RPL is more common than the secondary one. About 49 respondents belong to 20 to 30 years of age. Here, I like to mention that pregnancy loss rapidly increases after the age of 40 years. About 44% belongs to middle socioeconomic status, and about 52% completed their secondary education. About 12% having consanguinity of marriage, and there are very few studies regarding the relationship between consanguinity and RPL. Among them, the recent one is held at 2020, where consanguinity increased homozygosity of autosomal recessive conditions. Their result implicates the involvement of some autosomal recessive genes in the pathogenesis of RPL. About 27 respondents having irregular menstruation, and we know that irregular menstruation may be associated with endocrinopathies. About 55% having more than 25 BMI, and couples with RPL should be informed that maternal obesity and being significantly underweight is associated with obstetric complication and could have a negative impact on their chances to live birth and on their general health. About 7 respondents having diabetic, 18 having thyroid disorder, 12 having hypertension. And there are many relationships between medical disorder and RPL. Here, I would like to mention, for example, thyroid screening as TSH or thyroid peroxidase antibodies is recommended in women with RPL. And treatment of women with subclinical hypothyroidism may reduce the risk of miscarriage. And the preconceptional counseling is the scope where we can do the workup. When I terms negative psychological effects such as pregnancy-related anxiety, depression, irritability, excessive fatigue, fear, sleep disorder, and lack of concentration. So, I would like to conclude my session that preconceptional counseling is the golden opportunity for healthcare provider to evaluate the possible risk factors of RPL. During preconceptional counseling, identification of demographic risk factors, suggestive sub-investigations may have some implication on appropriate management of RPL. And my recommendation is all pregnancy should be started with the preconceptional counseling, especially the high-risk pregnancy, as example RPL. And when during preconceptional counseling, we can identification if needed. We can advise for cessation of smoking, maintain normal body weight, limited caffeine consumption. We can advise for some suitable investigation, and we can encourage for regular antenatal checkup those who are becoming pregnant. And the most important thing is for RPL, psychological support from the caregiver as well as from the family. And the important thing another is tender loving care. Thank you.
Thank you, Dr. Dina Laila Hossain, for her very informative presentation. Now it's time to take comments from our Honorable Chairperson, Dr. Naima Sharmin Haq, Associate Professor, Department of Obstetrics and Gynecology, Z.H. Shikdar Women's Medical College and Hospital. Thank you.
Hello. Thank you so much. At first, I would like to thank our OGSB, our President OGSB and OGSB President-elect to give us the opportunity to enjoy such a nice first International Young Gynecologist Scientific Conference. And now, regarding the presentation, thank you so much to all of our first 3 presenters, Dr. Afroza Sultana, Dr. Sharmin Sultana, and Dr. Dina Laila Hussain. Really, endometriosis is now a daily is a stubborn issue in infertility, and we have to halt endometriosis at very early stage so that we can improve our fertility outcome. This endometriosis can ruin our life. If we can hold this at every and each early stage, then we can give a lady a satisfactory life. We can improve the quality of her life, as well as we can also improve her fertility. The use of amniotic fluid index in low resistance setting to improve the neonatal outcome in preterm prom cases is really appreciable. Thank you so much. The prolonged latency with individual management was associated with a significant reduction in the preterm birth, and it also reduced the NICU admission. All these things was done under the antibiotic coverages and maintaining hydration of mother with the amnio infusion and the normal saline. Nowadays, we the people are suffering from very low birth weight babies, and that increases the mortality to the babies, and it badly affect the perinatal outcome. So, according to our management protocol, this presentation was up to the full mark, and I'm congratulations again to the presenter. Regarding the recurrent pregnancy loss, actually it is a psychological stressful event for the couples and a challenging issue for the high risk specialist. So proper evaluation is necessary because most of the cases happens in first trimester, and for the evaluation of recurrent pregnancy loss, actually I think multidisciplinary approach should be our motto, so that we can ensure a quality life to the baby in future. Thank you so much.
Thanks to our Honorable Chairperson, Dr. Naima Sharmin Haq, for her nice words. Now it's time for our fourth speaker, Dr. Sriti Kona Bishas, to deliver her presentation. Dr. Sriti Kona Bishas.
Thank you, Dr. Tania. A very good morning. I, Dr. Sriti Kona Bishas, feel very much privileged to be here to present my study in front of this learned audience. My topic is oral nifedipine versus intravenous labetalol for acute blood pressure control in severe hypertension of pregnancy, a study at Faridpur Medical College Hospital. Hypertension is one of the common complications of pregnancy, and it contributes to maternal and perinatal morbidity and mortality. Delivery is the only treatment, and it leads to the disappearance of the disease. Hypertensive emergency is characterized by severe elevation of blood pressure more than 180 by 120 mm mercury and complicated by evidence of impending or progressive target organ dysfunction, that is central nervous system, cardiovascular system, or renal system. According to NICE guideline, gestational hypertension is severe when systolic blood pressure is more than or equal to 160 mm mercury, or diastolic blood pressure is more than or equal to 110 mm mercury, and recommended keeping systolic blood pressure less than 135 mm mercury and diastolic blood pressure below 85 mm mercury. NICE guideline recommended inpatient treatment of severe hypertension of pregnancy treated by labetalol, either oral or injectable hydralazine, oral nifedipine as the first-line antihypertensive to control severe hypertension of pregnancy. Labetalol, which is a non-selective beta blocker, which starts to act within 5 minutes, and its peak effect is found after 10 to 15 minutes, and antihypertensive effect persists for 45 minutes to 6 hours. Nifedipine, which is an oral calcium channel blocker, which starts to act within 20 minutes, and its peak effect is found after 4 to 7 hours, and its antihypertensive effect persists for 12 hours. The aim of our study was to determine the safety and efficacy of oral nifedipine and injectable labetalol in the acute blood pressure control in the setting of hypertensive emergency of pregnancy. This non-randomized prospective clinical trial was performed in the Department of Obstetrics and Gynaecology, Bangabandhu Medical College Hospital, former Faridpur Medical College Hospital, during 2013 to 2014. Total 50 admitted pregnant women with viable fetus and sustained severe hypertension were purposely selected and equally allocated in two groups. Patients were essential hypertension, bronchial asthma, diabetes mellitus, eclampsia are excluded from this study. In group A, 25 patients receiving oral nifedipine, and in group B, 25 patients receiving injectable labetalol. Each of the group A patient received 10 milligram of oral nifedipine, and the dose was repeated every 15 minutes interval until target blood pressure was achieved. In group B patient received injectable labetalol with incremental doses, that is 20 milligram, 40 milligram, and 80 milligram at 15 minutes interval until target blood pressure achieved. Each of the drug was tried for 5 doses. When failure of the on drug, the opposite on was tried up to 5 doses. When target blood pressure was achieved or trial of the both drugs are failed, the usual unit protocol are followed. If any patient developed hypotension or bradycardia, the trial was terminated and the patients are treated accordingly. During study period, maternal blood pressure was recorded every 15 minutes interval till first 30 minutes after achieving target blood pressure, then every 13 minutes for next 2 hours, then hourly. Continuous maternal vital parameters and electronic fetal monitoring are recorded. CTG tracing are taken at the beginning, then 2 hourly, then at the end of the study. Our primary outcome variables was time, that is minutes, taken to achieve the target blood pressure. And our secondary outcome variables are total antihypertensive doses, crossover to alternative antihypertensive, management at the end of the trial, either expedited delivery or expectant management, mode of delivery either cesarean or vaginal, 5 minutes Apgar score less than 7, maternal neonatal ICU admission need or not, and other side effect. Table on shows baseline characteristics of the patient. Mean age, maternal weight, on admission systolic blood pressure, diastolic blood pressure, and maternal heart rate are statistically similar for group A and group B patient. Table 2 shows time required achieving target blood pressure. After administration of the first dose, group 6 patients from group A and 4 patients from group B achieved target blood pressure. After second dose, or 30 minutes after administration, total 16 patients from nifedipine group and 12 patients from labetalol group achieved target blood pressure. After third dose and 45 minutes after administration, total 22 patients from nifedipine group and 19 patients from labetalol group achieved target blood pressure. And after fifth dose and 75 minutes after administration, total 24 patients from nifedipine group and 23 patients from labetalol group achieved target blood pressure. Table 3 shows secondary outcome variables are significantly similar for group A and group B patient. In our study, average time required to achieve target blood pressure for labetalol 30 minutes and for nifedipine 25 minutes. In Rahima et al., median time 30 minutes for nifedipine and 45 minutes for labetalol. However, in Dhalibi et al., nifedipine taken fewer time than labetalol. 2 patients from labetalol group and 1 patients from nifedipine group needed crossover to alternate treatment, and both achieved their target blood pressure within 30 minutes. Pregnancy-induced severe hypertension is an obstetric emergency. Early and effective management can prevent morbidity and mortality of both mother and baby. In our study, both intravenous labetalol and oral nifedipine are equally effective in reducing maternal blood pressure when used in repeated doses. Both are well tolerated. So in our country, nifedipine may be preferable as it is simple, flat dose schedule, and is an oral regimen. To attain at a definite decision, it is suggested that long-term, multi-center, well-designed randomized control trial with larger sample size to assess the safety, efficacy, and tolerability of labetalol and nifedipine, proper antenatal care with early detection, counseling, and management of severe pregnancy-induced hypertension. Thanks for patient hearing.
Thank you, Dr. Sritikona Biswas, for her very informative and talented presentation. Now I am requesting our fifth speaker, Dr. Monira Jamal, to deliver her presentation. She is Assistant Professor, Chattogram Ma O Shishu Hospital and Medical College. Dr. Monira Jamal.
Thank you for giving me this opportunity. A very good morning to you all. I am Dr. Monira Jamal. My presentation topic is cesarean scar ectopy pregnancy and early pregnancy near miss. An ectopic pregnancy is one when fetal tissue implants other than normal site in uterus near fundus. But when blastocyst implanted on a previous cesarean scar, it is known as cesarean scar ectopic pregnancy or CSEP. It is rarest of all ectopic pregnancy, and CSEP is associated with high morbidity and mortality. An estimated prevalence of 1 in 2,000 pregnancies is cesarean scar pregnancy and 6% of all ectopic pregnancies. The increasing trend is considered a consequence of increasing rate of cesarean section deliveries. And early diagnosis and well-planned management are important to save the uterus, preserve fertility, as well as to prevent morbidity and mortality. There are two types, type 1 or endogenic, where the gestational sac implanted in prior scar with progression towards the subischemic space or uterine cavity. Type 2 or exogenic, it is caused by deep implantation into scar defect with infiltrating growth into the uterine myometrium, into the serosal space and bladder wall. It is important to identify the type as it helps patients counseling on expected management as well as determination of medical or surgical management. Case report. A 35 years old lady with history of 2 previous cesarean section presented with 9 weeks of amenorrhea. She came to discontinue her pregnancy, which was confirmed by herself with urine sample at home. On examination, her vitals were within normal limit, no abdominal tenderness nor any paravaginal bleeding. She was advised for an ultrasonography of lower abdomen to confirm the pregnancy as well as the site of pregnancy. But the USG report revealed that the uterus was gravid and a single gestational sac was seen in the anteromyometrium of lower uterine segment within old CS scar, which correspond to 6+ weeks of gestation and indicate the endogenic type of CSAP. These are imaging findings. After the initial finding, the patient was advised to admit in hospital for clinical evaluation and advised for TBS and serum beta-HCG. But the patient decided herself not to admit in hospital and traveled to overseas, where she diagnosed with CSAP by TBS. In the meantime, she developed paravaginal bleeding while in the overseas, but she planned not to admit in overseas, rather return back to Bangladesh. In Bangladesh, she consulted for persistent vaginal bleeding and a repeat vita-HCG was done. The value was found more than 1 lakh. On admission, she was anemic, hemoglobin percentage 8%, pulse 100, blood pressure 90/60. The abdomen was tender and mild baby bleeding present. A TVS was done. It reveals that the ectopic mass had invaded the scar with impending rupture near the scar. Her clinical condition was deteriorating and planned for surgery. After opening of the abdomen, the anterior wall of uterus was found adherent to the bladder peritoneum. Once adhesiolysis performed, the mass was protruding at the right corner of previous scar of uterus. The sac was removed by suction with excision of old scar. After suturing of excision area, oozing was present, and so spongestin applied to control bleeding. A volume catheterization was done for proper hemostasis. 1 unit of blood was transfused operatively to correct the anemia. The suction material was sent for histopathology and it reported residual changes with chorionic villi. These are perioperative pictures. The patient had an uneventful postoperative recovery. Another unit of blood was transfused postoperatively. The case we presented is a 35 years old patient who had previous history of 2 CS. In the event of 1 case series, the most scar ectopic pregnancy occurred after only 1 CS, unlike our case. The number of CS appeared to have no impact as an independent risk factor. Ectopic pregnancy involves with high rate of morbidity and mortality if not identified early and managed promptly. The most common presentation of CSCC is painless vaginal bleeding without any specific clinical sign. To diagnose the case, a TVS and color Doppler proved to be helpful. Initially, our patient was asymptomatic, but with the delay of her decision making, she progressively developed with symptoms like vaginal bleeding and pain. As a result, she needed 2 units of blood to correct her anemia. Medical management has the advantage of being non-invasive but needs thorough counseling regarding the risk of hemorrhage, long-term follow-up with serial ECG measurement with the possibility of surgical intervention including hysterectomy. Traditionally, methotrexate has been reserved for beta-HCG level less than 5,000 and it takes a long time to normalize the level. In our case, medical management with methotrexate was not ideal choice because the patient beta-HCG level was more than 1,000 and pulse rate gradually increasing, though the patient was stable at the beginning. On the other hand, surgical management facilitated complete removal of conceptors, faster recovery, shorter follow-up due to rapid normalization of HCG level. Surgical excision of scar for cesarean scar ectopic pregnancy cases is also considered a vital management and effective to prevent recurrence. Perioperatively, we used spongestin to create a barrier together with fibrin to stop bleeding in 2 to 20 minutes and would be completely reabsorbed in 4 to 6 weeks. The surgery is done by dissection of old scar with repair. As a result, the chance of recurrence is less. In conclusion, CCP is a life-threatening complex condition with an increasing rate in recent years. An early accurate diagnosis and effective treatment plan are vital to reduce mortality and morbidity. TBS scanning, ultrasound, and training should be available for accurate and timely diagnosis. A misdiagnosis with delayed decision-making may lead to uterine rupture, hemorrhage, or even maternal death. Patient counseling plays an important role to educate patients to avoid delay to initiate treatment. The treatment plan should be designed to maximize the patient's benefit by giving priority to preserve the future fertility and prevent recurrence. This last two slide, including the references. Thank you for patient sharing. Thank you all.
Thank you, Dr. Monira Jamal, for her brilliant presentation. Now it's time for our sixth speaker, Dr. Shapla Khatun, to deliver her presentation. She is working as an assistant surgeon, Chuadanga Shodor Hospital. Dr. Shapla Khatun. Full screen.
Thank you, Dr. Mitul. A warm and pleasant good morning to everyone. I, Dr. Shapla Khatun, very much delighted to present my research topic in this very reputable platform. Title of my research, Low Dose Aspirin in Prevention of Preeclampsia. Preeclampsia is a multi-organ disease of unknown etiology. It typically affects 2 to 5% of pregnant women. Globally, 76,000 women and 5 lakh babies die each year from this disorder. In Bangladesh, the incidence is alarmingly high. About 20% of maternal death associated with preeclampsia and eclampsia. Aspirin works primarily through inhibition of COX-1 and COX-2 isoenzyme. But at low dose, it irreversibly acetylates COX-1, resulting decreased synthesis of thromboxane A2 without affecting prostacyclin. Cochrane meta-analysis reported antiplatelet agent reduced the risks by 19%, who also recommend low-dose aspirin. Preeclampsia is a preventable disease. Low-dose aspirin can prevent preeclampsia and also preterm birth and growth restriction. Though it is a proven study, but relevant evidence in Asian women is very limited. Bardem is a center of excellence where majority patients are high risk. Therefore, the study was designed to evaluate the role of aspirin in reducing the incidence of preeclampsia. Objectives of my study were to find out the primary outcome, that is occurrence of preeclampsia, and also to detect the secondary outcomes, gestational hypertension, oligohydramnios, preterm birth, antepartum hemorrhage, low birth weight, preterm birth, small for gestational age, IUD, stillbirth, and NICU admission. This randomized control trial was conducted on Bardem to General Hospital from 2018 to 2020. Here, the consort flow diagram showing the study procedure. 230 participants were evaluated. Among them, 30 participants were excluded, and 200 participants were randomized into intervention and control group. Randomization was done through lottery in a sealed envelope. The randomization number determined who will take aspirin and who will not. Only the intervention group were allocated to take 75 milligram aspirin after lunch. All the participants were followed up at 24 weeks, 32 weeks, 36 weeks, and weekly till delivery. And outcome variables were measured. Analysis was done and finally compared. Adherence of aspirin intake was assessed during each follow-up by checking the strips of aspirin. Selection criteria: pregnant women with live fetus 12 to 19 weeks had to fulfill any one of the following: maternal age 18 or above, BMI 30 kg per meter square or above, pregnancy interval more than 10 years, multiple pregnancy, pregnancy assisted by ovulation inducing drugs or IVF, family history of hypertension, gestational hypertension, preeclampsia, pregnancy with medical disorders, previous history of gestational hypertension, preeclampsia, eclampsia, and IUGR, IUD, and stillbirth. Here the table showing the risk factor of my study population. The highest risk factor I found, family history of hypertension, then hyperglycemia in pregnancy. There was no significant side effect was noted during the study period. Here the table showing the mean systolic blood pressure was 127.6 plus minus 17.5 in intervention group and 147.5 plus minus 19.5 in the control group, and mean diastolic blood pressure was 85.2 plus minus 11 in intervention group and 96.6 plus minus 14 in the control group. Result was statistically significant. There was also significant proteinuria noted in the study period. The table showing only 8 patients developed preeclampsia in the intervention group, but 48 patients developed preeclampsia and 31 patients developed gestational hypertension in the control group. It was statistically significant. But there was no significant difference was noted in the term and preterm preeclampsia and the gestational weeks of delivery. Finally, I found low-dose aspirin reduced the risk of preeclampsia 78% in the intervention group. Relative risk was 0.22. It was statistically significant, but there was no significant result was found in the development of gestational hypertension and other maternal outcome except mood of delivery. Here we are showing only one patient delivered pervaginally in the control group. And there was no significant result was noted in their fetal outcomes. There are some studies which support my study. So, the randomized control trial suggests that low-dose aspirin can significantly reduce the risk of preeclampsia if started at 12 to 19 weeks, but it does not significantly reduce the incidence of gestational hypertension, oligohydramnions, preterm labor, preterm birth, small for gestational age, IUD, stillbirth. Recommendation: pregnant women at risk of preeclampsia should be prescribed 75 mg aspirin if started from 12 to 19 weeks of pregnancy and continue up to 36 weeks or delivery, so that the chance of occurrence of preeclampsia becomes significantly less. Here are some references. Thank you.
Thank you, Dr. Shapla Khatun, for her genius presentation. Now it's time to take comments from our Honorable Chairperson, Dr. Shanta Tripedi, Junior Consultant, Reproductive Endocrinology and Infertility Unit of Dhaka Medical College Hospital. Dr. Shanta Tripedi.
Thank you, Dr. Tania, and very good morning to all. Congratulations to our speakers for their informative presentation. It's my great pleasure to have the opportunity to chair this prestigious session. Actually, prevention has no alternative for any kind of disease. So if we can prevent preeclampsia, we can prevent eclampsia, which is an important cause of mortality in our country. And regarding aspirin, besides the aspirin, there are some studies that are going on, use of bed rest, marine oil and garlic supplementation for prevention of the preeclampsia. So establishment of the preventive measure for the preeclampsia is a burn issue nowadays. And for the treatment of severe hypertension in preeclampsia or eclampsia, use of oral nifedipine will help us to avoid the hazards that are related to the injectable levodopa, which sometimes become life-threatening. Ectopic pregnancy is an emergency. Prediction, early diagnosis, and prompt intervention is necessary for the management of the woman and save her life. Thanks everyone for your patience hearing.
Thank you, Dr. Shanta Trivedi, for her kind comments. Now I am requesting our Honorable Advisor, Professor Morium Faruqi Shati, Chief Consultant, Labit Specialized Hospital and Hope Infertility Care and Counseling Center. Please, Madam, Professor Morium Faruqi Shati.
সম্মানিত সুধীবৃন্দ, শুভ সকাল, আসসালামু আলাইকুম। এই তোমরা যে ইয়াং গাইনোকোলজিস্ট, সেটা কিন্তু আমাদের বলার কিছু নাই। কবি নজরুল বলে গেছেন, মোরা ঝঞ্ঝার মতো উদ্যম, মোরা ঝর্ণার মতো চঞ্চল, মোরা বিধাতার মতো নির্ভয়, মোরা প্রকৃতির মতো স্বচ্ছ। সব কিছু তোমাদের কথা বর্ণনা করে দিয়ে গেছেন, যেন আমাদের তোমাদের প্রশংসা করা না লাগে। সেই কবে তিনি বলে গেছেন। আচ্ছা, এইবার হলো যে থ্যাংক ইউ ভেরি মাচ আমার ইয়াং স্পিকার্স, Dr. Afroza, Dr. Shamrin, Dr. Dina, Dr. Sritikona, Dr. Munira, Dr. Shapla, তোমাদের এক্সেলেন্ট প্রেজেন্টেশনের জন্য খুবই ভালো হয়েছে, সবার খুব সুন্দর হয়েছে এবং খুবই সুন্দর হয়েছে এবং টপিকস ওয়ার অ্যাপ্রোপ্রিয়েট, টাইম ডিমান্ডিং অ্যান্ড ভেরি ওয়েল ইলুমিনেটেড। যদিও চেয়ারম্যান দুইজন খুব সুন্দরভাবে প্রত্যেকটা স্পিকারসের স্ক্রুটিনি করে সুন্দর করে বলেছেন, তবুও আমার হার্টিয়েস্ট কংগ্রেচুলেশন তোমাদের। প্রত্যেকটা জিনিস সুন্দর, প্রথম থেকে যে টাইমলি শুরু হয়েছে, সবাই ঠিক এসেছেন টাইমলি। আমি জানি না আমরা এত মেনটেন করতে পারতাম কিনা, পেরেছিলাম কিনা, তো আমাদের উপরের সিনিয়র ম্যাডামরা বলবেন হয়তো। আর সবাইকে হার্টিয়েস্ট কংগ্রেচুলেশন এবং আরও কংগ্রেচুলেশন ব্যাকড্রপে যারা ছিলেন আমাদের লেজেন্ড সব সিনিয়র গাইনোকোলজিস্ট, ওদেরকেও ধন্যবাদ এবং সবচেয়ে শেষে ইয়াং গাইনোকোলজিস্টদের ধন্যবাদ। তোমরা মশাল নিয়ে এগিয়ে যাও, আশা করি সুপথ পাবো। থ্যাংক ইউ ভেরি মাচ।
Thank you, Professor Morium Faruqi Shati Madam, for her words of wisdom. Now we are at the end of the session. We are running short of time. So if you have any questions, please ask our honorable speaker at the lunchtime. Now I would like to request our rapporteur to deliver a formal vote of thanks.
Thank you, Dr. Mitul. This is my pleasure to thank the honorable advisors, chairpersons, all the speakers and moderator to run the session so successfully. Their discussion has enriched our knowledge enormously. I would like to thank all our participants who joined with us today. Thank you everyone.
Now we are requesting to our honorable advisors and chairperson and speakers and others of the session to have photo session.
হ্যাঁ সেকেন্ড সেশন না হ্যাঁ হ্যাঁ ইনফার্টিলিটি তারপর কোনটা দিব? না না এটা হচ্ছে ব্যাক ফরওয়ার্ড, এটা ব্যাকওয়ার্ড। হ্যাঁ কানেক্টেড করতে হবে না, না দিয়ে রাখি আমরা, অসুবিধা নাই। কানেক্টেড হয়নি তো, স্ক্রিনে দিয়ে দেন না, এখন দিয়ে দেন।
Ladies and gentlemen, participants from home and abroad, good day to you all. I am Dr. Indrani Kaur, currently working as Registrar, Gynecology and Obstetric Department, Sher-e-Bangla Medical College and Hospital, Borishal. Welcoming you all to the prestigious and very first International Young Gynecologist Scientific Conference 2022 organized by Obstetric and Gynaecological Society, Bangladesh. Our session is panel discussion on infertility, which is a agony of life that cannot be alleviated with anything but a child. It's mainly focusing on different aspects of male and female both infertility and the way to alleviate them, lessen them, to get rid of them. That is very important for our national perspective. This is my pleasure to hand over the microphone to our moderator, Dr. Pushpita Sharmin, currently working as Medical Officer, Subspecialty Course, Department of Reproductive Endocrinology and Infertility, Bangabandhu Sheikh Mujib Medical University, Bangladesh.
Thank you, Dr. Indrani Kaur, for your nice introduction. I would like to request our Hall Supervisor, Dr. Sanjida Sultana, to lead our honorable advisors to their seats. It's my honor to introduce our honorable advisors, Professor Parvin Fatima, ex-chairman, Reproductive Endocrinology and Infertility Department, Bangabandhu Sheikh Mujib Medical University. Professor Mosammad Rashida Begum, Vice President, OGSB. Major General Professor Lija Choudhury, Cultural Secretary, OGSB. Professor Shamsun Nahar Laki, Past President, OGSB, Khulna Branch. Thank you, Madam, for having your seats. Now I'd like to request our Honorable Chairperson of this session to have their seats on the stage, Dr. Urmila Mojumdar, Registrar, Shohid Ahsanullah Master General Hospital, Tongi, Gazipur. Dr. Sharmin Naz, Junior Consultant, Border Guard Hospital, Dhaka. Thank you for having seats. Dear audience, in this session, we have keynote presentation and an interactive panel discussion session. I have the honor to introduce our keynote speaker, Professor Preeclampsia Ganon. He is President, Asia Oceania Federation of Obstetrics and Gynecology. He is convener, Cochrane. We have 6 young expert panelists in this session from home and abroad. It's my great pleasure to introduce our panelist, Dr. Umme Salma, Registrar Reproductive Endocrinology and Infertility Department, Dhaka Medical College and Hospital, Dr. Sharmin Nahar, Medical Officer and Subspecialty Course, Reproductive Endocrinology and Infertility Department, Dhaka Medical College Hospital. Dr. Munmun Islam, FCPS Subspecialty Course, Reproductive Endocrinology and Infertility Department, Bangabandhu Sheikh Mujib Medical University. Dr. Nusrat Mehzabin, Assistant Professor, JDS Shikhtar Women's Medical College and Hospital. Dr. Damadar Rao, he is Joint Secretary of Indian Association of Gynaecological Endoscopists. He is joined with us on virtually. Our next panelist, Dr. Naushin Yasmin Tonni, is working as Medical Officer in Mugda Medical College Hospital, Dhaka. Now, with the permission of advisors and chairperson, I would like to start our session of infertility session. I would like to request our keynote speaker, Professor Preeclampsia Ganon, to deliver his presentation on evidence-based reproductive health practices, a systemic review and meta-analysis. We'll hear this presentation on recorded voice, and he's present with us. He's present with us on virtually. Now we are sharing his screen on online. Please connect him with the screen. Professor Preeclampsia Ganon,
ladies and
he is
gentlemen.
on live with us. We'll deliver his keynote
Chairperson,
presentation.
ladies and
Let's start.
gentlemen. I would like to sincerely thank the Obstetrical and Gynaecological Chairperson, ladies and gentlemen. I would like to sincerely thank the Obstetrical and Gynaecological Society of Bangladesh for the very kind invitation. The topic of my presentation today is evidence-based reproductive health practices, a role of systematic review and meta-analysis. I don't have any conflict of interest in my presentation today. The outline of
Excuse me. Recordedটা ছেড়ে দেন, recordedটা। হচ্ছে না তো। হ্যাঁ, sir, please continue. We are connected with you. Please continue, Professor Preeclampsia
today
Ganon.
is evidence-based reproductive health practices, a role of systematic review and meta-analysis. I don't have any conflict of interest in my presentation today. The outline of my presentation include the concept of evidence-based medicine, research synthesis, Cochrane collaboration, and now called Cochrane. Cochrane Library, and example of evidence-based sexual and reproductive health practices. What is evidence-based? The National Institute for Health and Care Excellence, or NICE, define as the evidence-based as the process of systematically finding, appraising, and using research findings as the basis for clinical decision. What is evidence-based clinical practice? Evidence-based medicine involves making decisions about the care of individual patients based on the best research evidence available, rather than personal opinions or common practices, which may not always be evidence-based. Why is evidence-based practice important? All of us want the best possible care for our patient. Keeping up to date is very difficult nowadays because science accumulates very rapidly. New evidence from research is often slow to be implemented. Established practices persist even if proven ineffective or harmful. And now in many countries, medical lawsuit is increasing very rapidly. Professor Archie Cochrane in 1979 criticized the National Health Services of the UK that it is truly a great criticism of our profession that we have not organized a critical summary by specialty or subspecialty, and it has to be adapted periodically of all relevant randomized control trial. At that time, the quality of evidence was rated as level 1, evidence obtained from at least one properly designed randomized control trial, followed by evidence obtained from well-designed control trial without randomization, evidence obtained from well-designed cohort or case control study, preferably from more than one center or research group, evidence obtained from multiple time series with or without intervention, and the lowest one was opinion from respected authorities. We have problems. Healthcare personnel need update information. Textbooks are out of date sooner than before. Journals are disorganized and limited. We have too much information, good and bad. We have time limitation because we have so many responsibilities. Therefore, our knowledge and performance deteriorates. Theoretically, when we have research findings, usually we have more than one research finding on the same topics. We need to do research synthesis to summarize all the research findings that are available in the world, to get the critical summary so that we can develop clinical practice guidelines to be used in our patient care. And we do need to do regular audit on this clinical practice guideline. The concept of research synthesis is that the result of a particular research study cannot be interpreted with any confidence unless they have been considered together with the result of other studies addressing the same or similar question. Therefore, research synthesis is the process to which two or more research studies are assessed with the objective of summarizing the evidence relating to a particular question. Research synthesis consists of two steps, starting from systematic review and followed by meta-analysis, if appropriate. Let me show you this forest plot evaluating the effect of corticosteroid versus placebo or no treatment in mother with preterm labor to prevent or reduce respiratory stress syndrome in the newborn. The left-hand column is the name of the city that the study was conducted. This column is experimental group. This is control group. This is fetal-odd ratio or risk ratio. Let's focus on the first study, which was conducted in Amsterdam in 1980. There were 64 mothers who received corticosteroid in the experimental group, and 11 neonates developed respiratory distress syndrome, while 58 mothers in the control group who did not receive corticosteroid, 17 neonates developed respiratory distress syndrome. This slide shows you the relative risk or odds ratio and the 95% confidence interval. You see that the odds ratio was less than 1, which indicated by this line. It means that mother who receive corticosteroid has a reduced risk of developing respiratory distress syndrome in the newborn. But it was not statistically significant because the upper limit of the 95% confidence interval exceeds 1. What about this study number 2, which was conducted in Auckland in 1972? More than 500 mothers received corticosteroid. 49 newborn developed respiratory distress syndrome, while also more than 500 mothers who did not receive corticosteroid in the control group, and 84 newborn developed respiratory distress syndrome. This slide also shows the reduced risk in the mother who received corticosteroid, and the 95% confidence interval did not reach 1, which indicates that it was statistically significant. There were altogether 18 studies that we obtained from the systematic review. If you look closely at this study, the direction of the effect usually fell on the left side of the one line, which indicates a protective effect. But very few studies in which the result is statistically significant. This black diamond-shaped sign indicates the result of meta-analysis, in which we combine all the studies together, having 1,885 mothers who received corticosteroid and 292 newborn developed respiratory distress syndrome, while 1,850 mothers did not receive corticosteroid and more than 400 newborn developed respiratory syndrome. This slide shows very clear protective effect of corticosteroid in developing respiratory distress syndrome. This is the very useful benefit of meta-analysis, which indicate very clearly the protective effect of corticosteroid. After we obtain the knowledge of the systematic review and meta-analysis, research synthesis of randomized control trial was led to be of the highest quality of evidence, followed by randomized control trial, followed by one design control trial without randomization, cohort study, case control study, and opinion form respected authorities. This slide shows you the website of Cochrane. And the vision of Cochrane is trusted evidence, informed decision for better health. Let me summarize the development of Cochrane for you. Cochrane was previously known as Cochrane Collaboration. It was founded in 1993 under the leadership of Sir Ian Chalmers. It was developed in response to Professor Archie Cochrane's call for up-to-date systematic reviews of all relevant randomized controlled trials in the field of healthcare. It was formed to organize medical research findings to facilitate evidence-based choice about health intervention involving health professionals, patients, and policy makers. Cochrane produced systematic reviews of primary research in human healthcare and policy. Each Cochrane review addressed a clearly defined formulated question. Cochrane is an independent, diverse global organization that collaborates to produce trusted, synthesized evidence, make it accessible to all, and advocate for its use. Cochrane work is now internationally recognized as the benchmark for high-quality information about the effectiveness of healthcare. It includes 53 review groups that are based at research institutes worldwide. Cochrane now has approximately more than 30,000 volunteer experts from around the world working together. The group conducts systematic review of healthcare intervention and diagnostic tests and publish them in the Cochrane Library, which is an online electronic journal. This slide shows you the picture of website of Cochrane Library. In 2021, the journal impact factor of Cochrane database of systematic review or Cochrane review was 12.008, which was very high compared to other journals. A Cochrane review was cited once every 6 minutes in 2021. Let me show you an example of Cochrane review that was published in Cochrane Library. This was the skin preparation for preventing infection following cesarean section. It was conducted by my colleagues in Indonesia. This slide shows you the structure of the Cochrane review. This is the abstract, which is a structured abstract. Cochrane review also has plain language summary so that lay people can understand the effectiveness and adverse effect of anti-intervention published in Cochrane review. The other unique feature of Cochrane review is the summary of finding. For example, this one, summary of finding of metacylino with iodine versus iodine alone for preventing infection following cesarean section. And the outcome is surgical site infection, endometritis. And they have the relative effect and 95% confidence interval. They also have information about number of participants, number of study. And they also indicate certainty of evidence as very low or moderate or high. About 15 years ago, we were very lucky that our 4 countries in Asia, including Malaysia, Indonesia, Philippines, and Thailand, together with 3 universities in Australia, including Monash University, University of Sydney, and University of Adelaide, obtained funding from your Trust and Australian government to implement the use of evidence-based practice in pregnancy and childbirth. Southeast Asia, optimizing reproductive and child health in developing countries. And we published our project in PROS 1. And in this, one of the important component is research capacity strengthening. And this is one of our products from this research capacity strengthening. This is a picture show about the vacuum extraction in some mother who cannot deliver their baby spontaneously vaginally and need assisted vaginal delivery by vacuum extraction. We need to apply the cuff to the fetal head, and we were taught to increase the negative pressure in a stepwise manner once every 2 minutes, and usually it requires about 10 to 12 minutes before we reach the adequate negative pressure before we can pull the fetal head downward. And we have a question from one of my colleagues from one of the provincial hospitals here in Thailand that do we really need stepwise method? Can we do it more rapidly? So our clinical question was using the PICO format. P participant is women who require vacuum extraction. Intervention is the rapid method of negative pressure application. Control group is the stepwise or conventional method. And the outcome was success rate and delivery outcomes for both the mother and the baby. Clinical question is that, is rapid negative pressure application as effective and safe as stepwise method? At that time, there was no Cochrane review on this topic, so I convinced my colleague Banpot Suwanachat from Kalasin Provincial Hospital to do the Cochrane review, and we found only one randomized control trial conducted in the Netherlands involving 94 women, and the duration of vacuum procedure was reduced by 6 minutes, and there were no significant difference in maternal and fetal morbidity. We conclude at that time that we don't have enough evidence to recommend any method over the other. What should we do next? We conclude that we need to generate evidence by conducting randomized control trial. We calculate the sample size and we require 660 women. So we have to do multi-center study. We spent only about 2 years in reaching the required sample size, and we published rapid versus stepwise application negative pressure in vacuum extraction assisted vaginal delivery, a multi-center randomized control trial, non-inferiority trial in British Journal of Obstetrics and Gynaecology. We are very pleased that Loiter Health in New York quote our study that rapid application vacuum extraction cut about 5 minutes from the typical procedure in a recent study. In some cases, this is critical period. That was the interview by me by email. We update our Cochrane review in the Cochrane library. And we conclude that the rapid negative pressure application of gradient in maternal and neonatal outcome. Rapid method of negative application should be recommended for vacuum extraction assisted vaginal delivery. We are very glad that Banpot got the award from the Thailand Research Council. William Obstetric 26th edition used our Cochrane review and primary study as a reference in their textbook, which is a world-leading textbook in obstetrics. Our other Cochrane review was also used for the WHO guideline for breastfeeding in facility, and this was a Cochrane review about antenatal breastfeeding education for increased breastfeeding duration. Other Cochrane review was used in the WHO recommendation for intervention to improve preterm outcome. The WHO recommendation provision of treatment for prevention and treatment of maternal peripartal infection, 4 year and 2 year. Altogether, 6 of our Cochrane review were used as reference in this WHO recommendation. Our take-home message to you is that we, as a practicing clinician, we need lifelong learning. I recommend routine to research, and then research back to routine work. I also recommend to use clinical question of PICO, and we need to do literature search by conducting systematic, if possible, with Cochrane review, so that we can have comprehensive search, list of bias assessment, data synthesis and interpretation. Sometimes, for example, in the vacuum extraction example, we need to generate new evidence by using appropriate study design with collaboration in multi-center study. We need to update the evidence regularly, and we have to implement our research finding. And one important issue is that we need to be a good role model as a teacher for our medical student and resident. Thank you very much for your very kind attention.
Thank you, Professor Pisik Lumbiganon, for your excellent presentation. Your presentation put thoughts for more organized research work. Now it is time to start our panel discussion session. We have 6 young expert panelists in our session, and my humble request to our all panelists to maintain their time strictly. So let's start our panel discussion session. And our first case scenario .
The outline of my presentation include
Let us hear the case scenario of Mrs. Amina, a 34 years old lady with regular menstruation, has been suffering from primary subfertility for 6 years, dysmenorrhea for 8 years, and dyspareunia for the last 4 years. She had received letrozole for 6 cycles. On investigations, hysterosalpingogram was done 6 months back, and it was found that her both tubes are patent. On evaluation, her AMH is found 2 nanogram per ml. On ultrasonogram, right ovary shows endometrioma about 3.5 into 4 centimeter, and left ovary shows unilocular cyst with internal echoes suggestive of endometrioma about 6 into 7 centimeter. Both ovaries are adherent to the posterior surface of the uterus. Husband semen analysis is normal. So my question is to Dr. Salma. What is your first choice of treatment and why? And if you want to do surgery in this patient, what will be your approach to save ovarian reserve? Dr. Salma.
Thank you. Thank you, Dr. Pushpita. Very good morning and assalamu alaikum to all learned audience. Though there is no clear recommendation in different guidelines for the treatment of stage 3-4 endometriosis associated infertility, but in ESHRE guideline, GDG recommends that treatment should be individualized according to the age of the patient, unilateral or bilateral endometrioma, size of the endometrioma, ovarian reserve, and estimated EFI. As the age of the patient is 34 years, she has bilateral endometrioma, and both ovaries are adherent with the posterior surface of the uterus. The serum AMH is 2 nanogram per ml. So, in case of this patient, cyst aspiration with or without sclerotherapy, followed by ART, may be the better option. In a recent literature, the age before 30, surgery could be considered if other fertility parameter is normal, and after 30 years, ART should be the first approach. And we all know surgery is associated with significant reduction of AMH, and which is 60% in case of bilateral endometrioma surgery. And there is 2.4% chance of premature ovarian failure. The recent cutoff point for serum AMH before surgery, 2.1 in case of unilateral endometrioma surgery, and in case of bilateral endometrioma surgery, this is 3. And surgery is also associated with possible surgical complications, and there is need surgical expertise, and surgery may be incomplete, there is recurrence of surgery and ultimate delay in ART. So, in case of ART, implantation is more better than surgery by freeze-all technique followed by fresh embryo transfer, frozen embryo transfer. But in low-resource setting countries like ours, surgery is still commonly done, yet IVF facility is not available and beyond affordability of our people. In answer of the second question, the surgical approaches to save ovarian reserve may be the combined ablation and cystectomy technique. And in case of this technique, there is less reduction of ovarian reserve and less chance of recurrence. And again, 3-stage cystectomy technique can be also done, where there is a laparoscopic cyst aspiration followed by 3 months generous agonist treatment, followed by again laparoscopy for cyst wall removal or ablation, but which is not feasible for our people. So we can do vaginal aspiration followed by generous agonist treatment, followed by laparoscopy, by which we can do ablation of the remaining cyst wall or cystectomy. But we have to remember, in case of surgery, the use of coagulation, diathermic coagulation should be very limited, and suturing is much more better than coagulation. So at last, but not the least, I want to say, in case of endometriotic patient with infertility, the treatment should be active, and early diagnosis, early treatment, and early referral is needed to reduce the time to live birth. Thank you all.
Thank you, Dr. Salma, for your nice explanation. Our next scenario is for Dr. Sharmin Nahar. Here is the scenario. Mrs. Kona, 29 years old lady, attended at the OPD with the complaint of primary subfertility for the last 6 years. She has irregular delayed menstrual cycle for last 10 years and excessive hair growth on her face and body for 3 years. She is overweight. Investigations revealed AMH 6 nanogram per ml, and ultrasonogram shows both ovaries enlarged and polycystic. She had received ovulation-inducing drugs several times without monitoring. So my question is to Dr. Sharmin Nahar. What is your plan of treatment and how will you stimulate the patient? Dr. Sharmin Nahar.
Thank you, Dr. Pushpita, for your nice question. Assalamu alaikum and a very good morning to everyone. This is a very common scenario in our day-to-day clinical practice, as she presents with polycystic ovarian syndrome, which is one of the most common cause of anovulation. Before going for her fertility treatment, she has to reduce her weight by diet, exercise, and lifestyle modification. I would like to add metformin with myoinositol for metabolic abnormalities. Before going to ovulation induction, semen analysis of her husband is a must. Previously, she has taken oral drugs without any monitoring. So now I would prefer to start her with letrozole from day 2 to day 5, and this time I will monitor her with serial folliculometry. TVS folliculometry helps to adjust the drug dose and also see the response of the drug. If oral drugs doesn't respond adequately, then I will add injectable gonadotropin. Usually we use recombinant follicle stimulating hormone 75 international unit. Initially we give on day 3 and day 8. Then successive doses will be adjusted according to her TVS findings. TVS findings is important in cases of injectable gonadotropin as it helps to adjust drug dose, see the response, and early diagnosis of hyperstimulation, which could be life-threatening for the patient. If she failed to conceive after 6 ovulatory cycle with oral drugs and injection, then for this patient, my next step will be to do a laparoscopy. For this particular patient, laparoscopy will help to assess her tubal patency, and some sort of drilling can be done if required. After laparoscopy, my steps of management will be as usual, such as oral drugs with injectable gonadotropin. Then I can do IUI for at least 3 cycles. If IUI fail, then I can go for in vitro. Then I will go for IVF, ICSI, or IVM. So my take-home message is lifestyle modification is the first line of management in case of an obese PCOS patient. And whether I use TVS folliculometry for oral drugs, this is a good practice, but this is mandatory for in cases of injectable gonadotropin. And before giving any ovulation-inducing drugs, to exclude the male factor and see the tubal patency is a must. Thank you all, and thank for patient sharing.
Thank you, Dr. Sharmin Nahar. You have very nicely explained what should we do in a case of polycystic ovarian syndrome patient that we always find in our OPD. Our next case scenario is Mr. Hassan, 32 years old male, a school teacher, came with subfertility for 4 years. He is found to have azoospermia on semen analysis. His history of mumps orchitis at 17 years of age. His wife is a healthy, regularly menstruating woman. So my question is to Dr. Munmun Islam. What preliminary investigations would you like to do for him, and how will you counsel the patient regarding the fertility treatment option? Dr. Munmun Islam.
Thank you, Dr. Pushpita. Assalamu alaikum and good morning to everyone. In our country and in the whole world, couple unable to get pregnant after 1 year of regular unprotected coitus accounts for nearly 10 to 15% in general population, and male factor accounts for this around 20 to 50%. Among these men, we found around 15 to 20% are azoospermic. As my given scenario is here, Mr. Hassan, he is 32 years old, a school teacher, and he is non-smoker. His duration of fertility is about 4 years, and he has got mumps, later on developed orchitis at his 17 years of age. Regarding his female partner, she is healthy and having regular menstrual cycles. So as we know, mumps orchitis is one of the commonest cause of testicular failure, which is grouped under non-obstructive azoospermia. So regarding his physical examination here, it is mentioned that his BMI is within normal limit. If we go for the genitourinary examination, his testis size estimated will be small, that is less than 4.6 centimeter in the long axis due to atrophy of the testis, and the epididymis can be found normal in sizes and the vas may be palpable. Now the investigation. Here it is mentioned that semen analysis, it is found agiospermia, but we have to repeat the semen analysis at least 4 weeks apart and after centrifugation to confirm the agiospermia. And if we go for an ultrasound of both testes, it will determine the size and volume of both testes as well as it excludes any varicocele. And regarding the hormonal picture, we can do serum FSH, serum LH, and serum testosterone. Here we can estimate that the serum FSH will be more than 7.6 milli-international unit per ml, and the serum testosterone might be found less than 300 nanogram per dl, that is below normal limit. And if we go for testicular biopsy to assess focal spermatogenesis, and we can do the genetic testing to exclude Y chromosome microdeletion. This couple is very much distressed when they, as the male partner is found agiospermic, so we should provide emotional support to the couple. And now for your second question, that is the treatment option. If the focal spermatogenesis could be found, or in other way, if the male is eligible for sperm retrieval, we can do for him bilateral micro-TC, that is testicular sperm extraction followed by ICSI. And if no sperm could be found, there are also two options like donor insemination, which is not practiced in our country, and adoption. In non-obstructive agiospermia, chances of sperm retrieval by micro-TC is about 40%, and live birth rate after micro-TC and ICSI is about 20%. So we can assure the couple about modern treatment modalities and hope that they may become a biological father and mother of a beautiful baby, inshallah. Thank you so much.
Thank you, Dr. Momin Islam. You very nicely explained what should you do in a case of agiospermia. Our next scenario, we are going to our next case scenario. Our next scenario is of Mrs. Nipa, a 27-year-old lady, married for 2 years, has been suffering from primary subfertility. She has infrequent scanty menstruation for 4 years. Now she is amniotic for the last 6 months. She has mental irritability and anxiety. She has no history of pelvic surgery or chemoradiation. Investigations revealed serum FSH 25 international unit per liter. She has 25 international unit per liter and AMH 0.05 nanogram per ml. So my question is to Dr. Nusrat Mehzabin. How do you manage this case?
Thank you, Dr. Pushpita. And Assalamu alaikum, very good morning to my respected and learned audience. Probably this is a case of primary ovarian insufficiency, but I have to reconfirm it with the HFA guidelines. She has already menstrual abnormality more than 4 months and she is under 40 years, but I would like to do the FSH level 4 weeks apart. If it is again come more than 25 international unit per liter, then it's a confirmatory case of premature ovarian insufficiency. Then I have to handle the patient with great sympathy and counsel her about the fertility options. Spontaneous chances of pregnancy is very much unlikely in such type of patients. So I would counsel her to refer to IVF center and consult with gynecological endocrinologist. And also in these patients, if good egg is, I would like to evaluate her ovarian reserve with AMH and interfollicular count. This patient has already very low AMH, so I will prefer IVF. If good quality egg is found, IVF can be done by her own eggs. But if maximum cases it's not found, there is also an option for donor eggs. But donor eggs is not very much available in our country, so we can go for newer options of treatment as stem cell therapy, PRP, OFFA, and growth factor to stimulate the dormant follicles of the ovary, and then go for IVF. And in such a patient, as the patient is only 27 years, IVF, the options of the IVF protocols are mini IVF, GnRH antagonist protocol, and microflare, GnRH agonist. As the patient is only 27 years, the chances of IVF, this protocol is about 18 to 33%. It is shown in the recent journals and researches. IVF has more chances of pregnancy, but it has also disadvantage. Also, I have to counsel with the patient. After that, I need to also counsel about the patient, her general health, including the cardiovascular system. She need to maintain a good bone mass density, and also we need to prevent the urogenital atrophy with a good HRT management. HRT is a very good option in such patients, and these are found in so much forms in our country also. It's now available. And to maintain, she needs to do regular weight-bearing exercises, and she needs also supplementation of calcium and vitamin D. And the doses can be varied according to patients. And last but not the least, 9 out of 10 patients suffer from severe mental grief, and it's also called silent grief. So I must refer the patient to a clinical psychologist for psychotherapy. Thank you.
Thank you, Dr. Nusrat Mehzabin. I'm requesting our audience to give claps to our young gynecologists. They are explaining every case scenario very nicely, and we can take home messages and guideline from them too. Please encourage them and give claps. Okay, thank you. We are going to our next case scenario. We are connecting with us Dr. Damadar Rao. He's from India. He's Joint Secretary of IAG, Tamil Nadu. Now he is with us virtually. My question for Damadar Rao, 28 years old, infertile couple, has come with primary subfertility, male partner unremarkable medical history. For the female partner, nothing significant in the history and examination. Semen analysis reveals oligoasthenospermia, concentration found 12 million per ml, motility 25% sperm with progressive motility, morphology was 4% normal sperm, and volume was 3 ml. So my question is to Damadar Rao, how will you manage the couple? Is there any role of medical treatment for oligoasthenospermia? Dr. Damadar Rao. Please unmute Dr. Damadar Rao.
I am on.
Unmute yourself.
Hello?
Yes, we can hear.
You can hear me now?
Yes.
Yeah, good morning, everybody. At the outset, I'd like to congratulate all of you on this wonderful Congress that's going on. And I also like to thank you for the opportunity given to me. Let's dive into the case straight away because a very short time. So, yes, this is a 28-year-old
Make a
couple.
full screen view, please.
Hello? Hello?
Hello, full screen. Give full screen, please, so audience can clearly view your slides.
Is this better?
Yeah. Yeah, thank you.
Yeah. So it's a 20-year-old male. And obviously, looking at his sperm parameters, we've come to the conclusion that he's already oligoasthenospermic because the counts are less than 15 million per ml. And motility, progressive motility is less than 32. And the morphology, we at least require about 4%, and it's only 0.4% here. And the volume is all right. But I think what I'm mainly looking at over here is the morphology is really, really on the lower side. So we really have to study this male and see what all can be done to him. Obviously, like our previous speakers have discussed, we have to look into pre-testicular causes, testicular causes, and post-testicular causes. But I've already been told that the medical history for this patient is almost normal. So what we're left is probably look into hormones and then probably do a scan to rule out varicocele or any past history of any infection. Many times it can just be idiopathic. Many times such things can be idiopathic, but you also have to rule out other endocrine causes like diabetes mellitus. Is he obese? Is he smoking? Look into all sorts of habits. And if there are any of these, then you have to correct all of these habits. You have to ask him to exercise, improve his lifestyle. If there is a varicocele, you can suggest, ask him to do a varicocele correction, but you also have to again, tell him that the success rate is only about 40%, does not work for everybody. About medical management, yes, you can try and give him a medical management for about 2 to 3 months and see if it works. Again, you have to tell him that it is not going to work for everybody, but there is no harm in trying. And if after a varicocele surgery or say a lifestyle improvement or after medical management, there is an improvement, then based on what improvement he gets, you can either ask him to try naturally or go for a IUI. But if nothing improves, I think he will require a IVF. This is what is my suggestion for the couple.
Thank you, Dr. Damadar Rao, for your nice elaboration of the management of this patient. We have a participant from home and abroad. Very expert young gynecologists are with us. We have panelists from our own country and from abroad also. So a very interesting panel session is going on. Please keep patience, everyone. Our next case scenario is for Dr. Naushin Yasmin Tunni. The case scenario is Mrs. Chorna, 32 years old, irregularly menstruating married lady for 7 years, attended the OPD for fertility treatment. The couple was seeking conception for the last 5 years and had ovulation-inducing drugs for several cycles. She was under regular follow-up. Folliculometry was used to show good follicles, and her day 21 serum progesterone was 24 nanogram per ml. But unfortunately, she failed to conceive. About 6 months back, she underwent a laparoscopic evaluation showing normal uterus and bilateral patent fallopian tubes. Husband's semen analysis report shows normal. So my question is to Dr. Naushin Yasmin Tunni, how are you going to manage this patient?
Thank you, Dr. Pushpita. Assalamu alaikum and very good morning to all of my respected teachers and learned audience. This case scenario represents the unexplained cause of infertility. It is one of the most common challenging situations we have to face in our clinical practice. Unexplained infertility is idiopathic, which means cause of the disease remains unknown even after thorough basic infertility workups. The investigations are semen analysis for male and assessment of ovulation by mid-luteal serum progesterone and assessment of fallopian tube and uterus by hysterosalpingography or laparoscopy. The diagnosis is made when all basic investigations does not show any noticeable causes. Let's understand what could be the possible reasons that pregnancy could not be achieved. There might be some issues related to the poor sperm quality or poor egg quality, problems in the lining of the fallopian tube, or defective endometrial receptivity or implantation failure. In this scenario, patient is 32 years old lady, married for 7 years and already seeking conception for 5 years, and she already took several cycle ovulation inducing drug. She was under regular follow-up and her day 21 serum progesterone folliculometry and her husband's semen analysis was good. So I think that her hormonal analysis such as serum ELIS, FSH, thyroid function test, prolactin was done prior to starting ovulation inducing drug. As she underwent laparoscopic surgery 6 months back, uh, I want to see the serum AMH level to see the ovarian reserve. For the treatment option, when a patient is confirmed unexplained infertility, we doctors suggest that not to stress. And counseling is very important. Counseling and reassure the patient. And first choice of treatment is ovulation inducing drug with IUI, that is intrauterine insemination for 3 cycles. Uh, ovulation inducing drug with IUI of 3 to 4 cycles have success rate about 40% according to the studies. And if ovulation inducing drug with IUI of 3 cycles fail to achieve pregnancy, then they can go for conventional IVF or ICSI. Conventional IVF was done, and ICSI has better pregnancy rate in case of unexplained infertility than the conventional IVF because it has less total fertilization failure rate. And so the treatment options is intrauterine insemination or IVF or ICSI. Thank you for patient sharing.
Thank you, Dr. Naushin Yasmin Tonne. Now, I would like to request our keynote speaker, Professor Pisik Lumbiganon, to give a short comments regarding our panel discussion session. Professor Pisik Lumbiganon, sir, would you please make including the panel discussion? Professor Pisik Lumbiganon. Oh, sorry, our connection is lost. So we are now at the end of this session. Now it's time to take comments from our honorable chairperson. I would like to request our chairperson, Dr. Urmila Mojumdar, to make some comments regarding the session. Dr. Urmila Mojumdar.
Thank you, Dr. Pushpita. My honorable advisors, foreign delegates, senior and junior colleagues, a very good morning to everyone. First of all, I would like to thank our keynote speaker, Professor Pisik Lumbiganon, for his excellent presentation on evidence-based practice of reproductive health. It is a very time-demanding issue. Evidence-based practice of reproductive health will benefit our patients from effective intervention and also protects them from any harmful ones. I'm also thanking our panelists for their very nice presentation, case discussion. I just want to say something about our first case scenario where the it was a case of stage 4 endometriosis where the patient age was 34 years. Yes, our first option is obviously ART for this patient. But if we consider, if we see the patient's socioeconomic condition doesn't permit her to do the ART, in that, as we know, in our country, only DMCH, in government sector, only DMCH is providing the facility for ART. In that case, we can go for surgery after doing the proper pre-surgical evaluation of the patient. Then gonadotropin stimulation followed by IVF for 2 to 3 cycles can be done. But most important is we should preserve the ovarian tissue during surgery, as there is more chance of diminished ovarian reserve after surgery. So lastly, I would like to thank our Obstetric and Gynaecological Society of Bangladesh for arranging the first International Young Gynaecologist Conference in Bangladesh, and we hope that it will continue in future. Thank you all.
Thank you, Dr. Urmila Mojumdar, for your kind comments. Now I'm requesting our honorable chairperson, Dr. Sharmin Naz, to give some comments regarding the whole session.
Thank you, Dr. Pushpita. Assalamu alaikum. A very good morning to you all. I'm honored and overwhelmed to be here in front of you. Thank you, participants from home and abroad, for joining us in this session. At first, I would like to congratulate our keynote speaker, Professor Pisek Lumbiganon, for his brilliant presentation on evidence-based reproductive health practice. Thank you, speaker. Actually, all of us know that protocols, policies depends on the results of researches. And here our speaker nicely elaborated the importance of evidence-based practice. Thank you, speaker. We had several discussions, talks on infertility in our panel discussion, which was very much informative and thought-generating. We enjoyed a lot. I just want to add one thing, and that is we, the young gynecologists, should practice maintaining medical ethics so that we will not be maleficent to any of our patients, rather we will be beneficent. Many thanks to our advisors, and thank you so much, audience, for joining us. Thank you, everyone.
Thank you, Dr. Sharmil Nath, for your kind comments. Now, I would like to request our Honorable Advisor, Professor Mosammad Rashida Begum Madam, for her words of wisdom regarding this session. Professor Mosammad Rashida Begum.
Thank you, Pushpita. Assalamu alaikum and good morning, my seniors, my mate and junior gynecologist. আমি একটা গল্প দিয়ে শুরু করি। একটা টেবিল টেনিস প্রতিযোগিতায় চেয়ারপারসনকে একটু মন্তব্য করতে বলা হয়েছিল। তো চেয়ারপারসন বললেন যে পোলা দুইটা তো খুব জোরসে পিটাইছে, ওদেরকে তো ধন্যবাদ, ওদের কি ধন্যবাদ দিব? আমি ধন্যবাদ দিই সেই মুরগিটারে যেই ডিমটা পারছে। তো আমাদের এই মধ্য গগনের উজ্জ্বল সূর্যের প্রখর তাপযুক্ত ইয়াং গাইনোকোলজিস্টদেরকে আমার অভিনন্দন এবং তাদের আজকের প্রেজেন্টেশনের জন্য আমরা সবাই বিমোহিত, তাদের অসংখ্য ধন্যবাদ। কিন্তু তার চেয়ে অবশ্যই ধন্যবাদ সেই মহিলাকে যে এই ধারণাটা প্রসব করেছে। এই সেই প্রসূতির যাতনার প্রত্যেক প্রসবের যেটা যাতনা থাকে, সেই প্রসূতির যাতনার সাথে অন্যদের যে যাতনা, সেজন্য তাদের অভিনন্দন। কোন যৌথ পরিবারের শাশুড়ির ছেলের বউরা চাবির গোছা পায় না, চাবির গোছা না পেলে কর্মক্ষমতাও দেখাতে পারে না, অথচ শাশুড়িকে সাহায্য করেই যায়। ইয়াং গাইনোকোলজিস্টরা সবসময় সিনিয়রদের পেপার লিখেই যাচ্ছে, তাদের কর্মক্ষমতা কখনো দেখাতে পারে না। কাজে এই প্ল্যাটফর্ম সাংঘাতিক রকমের একটা তাদের ইফোর্ট এবং তাদের যে যোগ্যতা সেটা দেখাবার জন্য একটা উত্তম প্ল্যাটফর্ম। ধন্যবাদ ফ্লোরাপাকে আবারও। তো আমার অনুরোধ থাকবে নেক্সট প্রেসিডেন্টরাও যেন সেম ধারাবাহিকতা মেনটেন করে। আমার একটা রিকমেন্ডেশন যে আমরা এই সাথে ফর হান্টিং অফ স্পিকার্স আমরা তাদের প্রেজেন্টেশনের একটা ইভ্যালুয়েশন করতে পারি। দ্যাট ইজ মোড অফ প্রেজেন্টেশন, কোয়ালিটি অফ রিসার্চ, কন্টেন্ট অফ দ্য প্রেজেন্টেশন অ্যান্ড টাইম ম্যানেজমেন্ট। এবং কোনো কোনো ক্ষেত্রে শুধু রিসার্চ পেপার না, আমরা রিভিউ পেপার দ্যাট ইজ টপিক দিয়ে দিতে পারি, সেটা যদি প্রেজেন্ট করে। কারণ বিভিন্ন কনফারেন্স সেমিনারে যে ইনভাইটেশন পেপারগুলো থাকে সেটা কিন্তু রিসার্চ পেপার না, রিভিউ পেপার। যে রিভিউ পেপার প্রেজেন্ট করতে হলে তার কন্টেন্ট কত সমৃদ্ধ হয় সেটার জন্য অনেক পড়াশোনা করতে হয় এবং সেটার ওয়ে অফ প্রেজেন্টেশন একটু ডিফারেন্ট। কাজে সেই টপিকগুলো যেন এরপরে আনা হয়, শুধু রিসার্চ পেপারই না। ধন্যবাদ সবাইকে।
Thank you, Professor Mosammad Rashida Begum, for your kind comments. Your words always encourages us to move forwards. Now I'm requesting our rapporteur, Dr. Indrani Kaur, for a vote of thanks. Dr. Indrani Kaur.
Thank you, Dr. Pushpita Sharmin. I am very much obliged and honored to be a part of this very first Young Gynecologist Conference. Today, it is my pleasure to thank our legendary advisors, an honorable chairperson and our smart moderator for conducting this session so beautifully and successfully. My thanks to all the speakers and all the panelists for their excellent deliberation, which has enriched our knowledge enormously. Thank you, the audience, for their patience hearing. Thank you all.
Now, this is the time for tea break. Before going to tea break, I would like to thank our audiovisual partner, Escape. I'm requesting them to start their presentation on video. I would like to thank all the audience for their patient sharing. So let us see the video of escape.
For tea break. Assalamualaikum, audience. Dear